हेलो।
हेलो।
हाँ निखिल, किससे बात करना चाह रहे हैं?
सर अभी कोई बोला था।
हमने
नहीं, पता नहीं, कोई वॉइस आया था बैकग्राउंड से।
कोरिया से टेस्टिंग हो गई हमारी।
अभी तो कोई बात ही नहीं हुआ। उस टाइम बात कर रहे थे, कोई बात ही नहीं हुआ कोरिया से।
अच्छा, और कौन कौन कनेक्ट होंगे आए? एक सेकंड।
Hello, are you hearing? Hello, Indo. Hi. Hello.
Okay, I'm good. Shall we quickly go through this PR thing? Do you want to tell us what is the plan?
Sure. So Katya and Yura have been working on this and they've submitted 2 draft chapters.
Hello.
हेलो सर, अभी वॉइस आ रहा है मेरा क्लियर?
हेलो
सर वॉइस आ रहा है आपको मेरा? हेलो
वॉइस आ रही है आपकी?
ठीक है सर, अभी मेरा वॉइस आपको मिल रहा है?
हाँ मिल रही है।
ओके, मैं भी पीपीटी शेयर करूं, आपको बताना मेरे को एक बार दिख रहा है, विजिबल हो रहा है नहीं हो रहा?
ठीक है।
क्या करने के लिए?
पूरा सेशन समझाना है कि
मुस्कुराहटों की कहानियां पूरब से, सुकून के किस्से।
सर अभी बॉडी आपको क्लियर मिल रहा है? हेलो
हाँ पीपीटी क्लियर है।
सर, आप लैन से कनेक्टेड है वाईफाई से?
क्या क्या बोल रहे हैं?
आप नेटवर्क कैसे कनेक्टेड है? वाईफाई के थ्रू कनेक्टेड है, लैन के थ्रू?
ये वाईफाई के थ्रू।
सर आप लैन से कनेक्ट हो सकते हैं, उसको स्पीड और अच्छा मिलेगा आपको।
एक मिनट रुकिए, होल्ड करिए।
क्योंकि आपका जो थोड़ा सा बैंडविड्थ का थोड़ा इश्यू लग रहा है।
Good afternoon to the team at PMJ. Good afternoon to the team at Korean Hira.
Hi.
Good afternoon.
Good afternoon, Ajay.
Hi.
Just saying hello. I will let you continue with your preparations, but just wanted to greet you. Lovely to see you all.
Yeah, thank you. Are we clearly audible and visible to you?
Yes, it's great.
Okay, cool. That's great. So now I'll move on to the preparations.
Okay.
You stay here. Yeah. We'll start the
I'm
session.
just wondering. I think we all see your screen. Will our presentation be the same size as when we see our presentations? Would it be the same size as your screen?
Yeah. So when we will put up the presentation will come in a bigger size.
In a bigger size. All right. Great.
Okay.
Thank you. Am I audible?
Yeah, you can stay here. You can just mute
Okay.
yourself, and if you want, you can turn off your video as well. And then you can turn it on at the time of session. Yeah.
चल रहा है
Jay.
Hi, Winnie.
I just want to make sure that my microphone works.
I think there's something wrong with your microphone.
You can't hear me?
No, it's not coming through. Can you hear me okay?
I can hear you. That's why I want to test.
I think it's got a lot of interference. Hey, Karen, can you hear? You're on mute now.
But you got my smile, right? Hello, Ajay. Hello, Winnie.
Hello. Hi, Sheena. We can't hear you, Sheena. I think you're on mute.
There's a little bit of static behind, is it?
Karen, can you hear Winnie?
Karen, can you hear me?
I can hear Winnie. You were a little bit crackly, but just speak a little bit more.
So it's cracky.
It's crackly and breaking up a little bit, yeah.
Same here, yeah.
Hello, can you hear me now? Hello?
Yes, we can hear you, Sheena.
Okay, great. Thank you.
Do you want to test Winnie's connection?
Yeah.
Hello. Hello, can you hear me? Hello.
I'm gonna get out and come back. Okay.
Sheena?
You
Hello.
hear me? Hi.
Hello.
Hello, we are from Hira, Korea. We'd like to check the Odeon connection.
Yes.
Can you hear us?
Yes, we can hear you. Can you hear us? Hello, can you hear us?
I can hear you.
Hi, Sheena, your voice is audible to us?
Yes, it is.
Hello.
Hello.
I'm from Niti Aayog and I'm audible.
Yes, Niti Aayog is audible.
And the video is already good quality.
Yes, it is.
Okay. Yeah, this is AJ.
Hey, Mark.
Hi, guys. Can you hear me?
Better.
I can hear you, yes. Can you say some more things?
Hi, AJ. Hi, Winnie. Hi, colleagues. Hi, Karin.
Hi.
Not completely clear.
You say?
Can you hear Mark?
I can hear you clearly, AJ, but can you hear me?
It's sort of breaking up a little bit.
I
Okay.
can hear Mark. I can hear Ajay. Ajay, can you hear me?
Oh, we can hear you
Your
quite
connection.
clearly.
Oh, good. Thank you very much. Hi, Karin.
Hey, that's a nice accent you have there.
Okay.
Am I breaking up still, Mark? Ajay? Ajay?
Hello. Hi.
How you doing?
Hi, JP.
Hello.
Hi, JP.
Hello.
Hi, JP.
Hi. Hello.
Hi, Srinath.
Hi.
Hi.
Oh, you can hear me. That. Can you hear me? Am I super clear now or good enough? I can hear all of you, but with a little delay.
I think your audio is Sheena online?
Okay, can you hear me? Yeah.
Yes.
Yes.
I can hear you.
Yeah, sometimes I may have to turn off my video because of the connection.
Good afternoon. Just testing from Indonesia. Can you hear us?
Yes, we can hear.
Oh, thank
Yes,
you.
you're audible.
Hi, am I coming through broken up still? Karen?
There's a bit breaking up, but it's choppy. But we can
Yeah,
hear
it's
you.
a bit broken, but it is better than earlier, Winnie. It is better.
Uh-huh.
JP, I wonder, do you have a light in your room? Because you're quite dark, right, with bright light behind you. So I'm wondering whether you have the option
Maybe
to
I'll close the shutters. Okay.
yeah, close the shutters and put on a light. I think that would be better. Hello, Mr. Reddy.
Hi.
Hi, Dr. Reddy.
Hi.
How are you?
Fine, thank you.
Hi, Pamundi. We can't see you with your mask, but that's good.
That's a very nice coffee mug, Dr. Reddy. Do you have one with the number 2 on it?
No, I don't think so.
Hello.
All right.
So good afternoon, everyone. Sheena, I think we can start, or will there be?
Good afternoon.
मेरा नाम विजय पाटिल है। मेरे बच्चे का नाम आदित्य पाटिल है। मैं बिजली मिस्त्री हूँ और मैं घर घर जाकर काम करता हूँ और बाकी समय खेती बाड़ी का काम करता हूँ। मेरे बच्चे का समस्या डिलीवरी के समय था, उसको ट्यूमर हो गया था। डॉक्टर के पास लेकर गया तो बताया ट्यूमर हो गया है। बोले 5-6 लाख रुपए खर्चा आ जाएगा। आयुष्मान भारत एक कार्ड बने से मेरे बच्चे का इलाज हो गया है। ये कार्ड नहीं होता तो फिर क्या करते हैं, थोड़ा सा आधा एकड़ जमीन है उसको बेचना पड़ता, फिर घर का है घर भी बेचना पड़ता। आज मेरे बच्चा ये है कि आयुष्मान कार्ड मोदी जी निकाला है, उससे अच्छा इलाज हुआ इस नाम।
शुरू हो गया, चाय कॉफी नहीं चाहिए।
Sheena?
Yes.
Can start?
Yes. Good morning, good afternoon, good evening, depending on whichever part of the world you are in. Thank you very much for joining day 3 of Arogya Manthan 2.0. The focus of today will be on sharing of international best practices. We will focus on experiences of PMJ and 4 other countries, including Korea, Indonesia, Philippines, and Vietnam that have made significant progress with the health insurance reforms. The event has 2 segments. In the first segment, we will focus on country-specific experiences. And in the second segment, we will have a very eminent set of panelists who will look at various key issues such as provider payment reforms, looking at how do you reach the missing middle, how do you expand the coverage, how do you get the money to expand the coverage, etc. So without much ado, I would like to turn to Dr. Indu Bhushan, the CEO of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, or what we call as ABPMJ, which is the world's largest government-funded health insurance scheme. And Dr. Bhushan is the CEO of ABPMJ, also the CEO of the National Digital Health Mission that was recently announced, and he is also the CEO of the National Health Authority, which implements both these efforts. And Dr. Bhushan has been at the helm of right from designing the scheme, and he is the first CEO of ABPMJ in the National Health Authority. So with that, I would turn to Dr. Bhushan to really set the context for our international experience sharing event today. And over to you, Dr. Bhushan.
Thank you very much, Sheena. And thank you, all of you, joining us today from all over the world. It's really indeed our privilege to host you today at the occasion of 2 years of completing our scheme Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And I think Ayushman Bharat is the youngest scheme among all the schemes that we are going to be discussing today in this session. And therefore, we can learn from each other in a big way. I believe there is no policy problem in the world that has not been resolved by someone, somewhere, in some country. So solutions for all problems probably are available. And in that spirit, we are going to be sharing some of our problems and hoping to seek solutions from you.
Remote connection ठीक नहीं आ रहा है.
To set the context, I'll present a brief summary of what we have done in last 2 years, some key lessons and some major challenges. Then I look forward to listening to your views, guidance and advice. I am happy to report that despite the slowdown in the uptake of the scheme after the COVID pandemic, we have been making healthy progress, healthy momentum. Out of 36 states and UTs that we have in the country, 32 of them have been implementing the scheme. We have provided close to 13 million treatments worth about 160 billion rupees. If we look at the savings that our beneficiaries have had, it's actually much more, about 300 billion rupees because of our competitive rates. We've issued more than 120 million e-cards. There are more than 23,000 hospitals which have joined us, out of which about half of them are private hospitals. We have more than 100,000 treatments that have been provided outside the state of the beneficiaries, as benefits in our scheme are portable. People can go out of their states. They're not bound to their states in terms of seeking services. In fact, it's a quite encouraging progress. However, the numbers do not tell the entire story. The impact of the scheme is actually far greater than what these numbers convey, and we have some important learnings from this scheme as well. As the first lesson is that it is indeed possible to implement a scheme of the size and complexity of Ayushman Bharat in a short period. The scheme has more than 500 million beneficiaries spread across 36 states and UTs, and are seeking treatments from more than 23,000 hospitals. The scheme could be launched in a very short period of less than 6 months because of two factors: technology and flexibility. Of course, technology provided the backbone, and I'll come to that later. The second factor, flexibility, has been the key. As you know, India has 36 states and UTs, and all of them are very different. They are very different in terms of their development context. They are very different in terms of their health care seeking behavior. They are very different in terms of their implementation capacity. Therefore, Ayushman Bharat, while it's at national level, is one scheme. It has one broad contours, but different states have included their own variations, and this flexibility has given them a greater meaning, and also it is giving a fertile ground for innovations and creativity. Second outcome is that Ayushman Bharat has provided a framework and IT infrastructure for health assurance and universal health coverage in the country. So states have used this framework to converge many other ongoing schemes, including in some cases schemes for the employees, government employees, with the Ayushman Bharat. Various central government ministries are also planning to use the infrastructure and the framework provided by Ayushman Bharat to converge their schemes. The third issue is quality of care. And what we've seen is that a demand side scheme like Ayushman Bharat has a potential for improving quality of the care. We've done that by mandating standard treatment protocols, and we've developed those for many of our packages, and by incentivizing quality through providing differential rates for hospitals which have better quality. Fourth issue has been use of artificial intelligence and machine learning, and that has helped us in preventing, mitigating, and deterring frauds. We've used these techniques creatively and developed algorithms for fraud prevention, and we are continuously improving on them to identify suspected cases of fraud and abuse. fifth issue is the end-to-end IT platform that we have created has proved to be very useful in the context of COVID. Our digital call center has been supporting the helpline for COVID, fielding millions of calls in last 6 months. Our database, which contains information about high-risk group, has been also very helpful in providing alert and services and advice to high-risk patients. Our IT system, our transaction management system, has been useful for many states in terms of tracking the treatment of COVID patients for both PMJ patients and non-PMJ patients. Therefore, this IT system came at the right time before COVID and has helped in terms of COVID response. Now, this IT platform is also proving to be a viable building block for a newly launched National Digital Health Mission. So there are many other challenges, but I am restricting myself to 5. But we have some challenges as well. As you know that we are a very young scheme, only 2 years. Next one. And we have huge number of challenges still, but I'll share with you 5 challenges. And first one is we need to strengthen continuum of care, need to have better linkages between primary, secondary and tertiary care. We need to strengthen our referral system and ensure better follow-up of our patients. Some of them actually might require lifelong support in terms of follow-up. Second, we need to be to get more private sector engagement, especially in terms of getting more quality private sector hospitals engaged with us. And in the long run, medium to long run, we need to have greater number of hospitals in the country, in a greater number of private sector hospitals, especially in tier 2 and tier 3 cities and many underserved areas and rural areas. And we are hoping that we can do that by providing greater incentives and working together with other parts of the government. Third, we need to continue and further deepen our work on prevention and deterrence of fraud and abuse. Fourth, we need to actually do much more for reaching poorest of the poor and many states where the uptake of the scheme has been less than in other states. And finally, we need to further strengthen our payment system and ensure that all hospitals are paid on time. Of course, as I was saying, there are other challenges as well. However, let me stop at this point and thank you all for joining us on this occasion. We look forward to your guidance on how we can and should deepen the scheme further. Thank you, and back to you, Sheena.
Dr. Vinod Paul, who is the member, a full-time member of NITI Aayog. NITI Aayog, or the National Institute of Transforming India, is a premier Government of India think tank. And Dr. Paul, I think it really needs no introduction because he is very well known both nationally and internationally, and has had many prestigious and has held many prestigious positions. One thing in the context of ABPMJ that I would like to highlight is that he has been very much part of the architecture of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and has really guided the whole scheme, prior to the scheme's inception, right from the design of the scheme to serving on the governing board of ABPMJ. So with this, I would really like to request Dr. Vinod Paul to provide his opening comments and what his reflections are, and what he sees as the vision for ABPMJ going forward, and what he sees as some of the key challenges that the scheme will need to encounter as we expand coverage under ABPMJ. Over to you, Dr. Paul.
Thank you, Sheena. Thank you, colleagues. Indu Bhushan ji, distinguished
colleagues, distinguished speakers from all across the globe, and distinguished participants within India, outside India. First and foremost, it is a day of celebration. We have completed 2 years of a fascinating universal health coverage program in our country, and our progress by any yardstick is so satisfactory, so reassuring, and so much of this is to the betterment of the lives of poor people. So very proud to be a part of this journey, and I compliment the great work that has been done by the National Health Authority and all the partners, and above all, the visionary leadership provided by our Prime Minister is in this particular program has been leading from the front and opening opportunities for all of our creativity to unfold and to get channelized for the mission of universal health coverage. Indu Bhushan ji has given us a brief snapshot of where we are. I like to flag 2 issues as I sit with you in the next hour or two to learn more about the wisdom from the experts, wisdom from other countries, because we are at an important point now in the rollout of Pradhan Mantri Jan Arogya Yojana. These 2 years, we have learned a great deal, we have delivered a great deal, and we do know that more than 12 million individuals at least have received various forms of treatment at secondary and tertiary care, private and government sector hospitals. That's a great achievement. People are getting used to the idea of access to services for complex diseases, and the nation is looking forward to how this program can now reach the next level in terms of its depth and expanse. I like to flag 2 issues, and I hope I'll be hearing ideas on those 2 issues. First issue relates to more of a nitty-gritty issue to which CEO NHA had alluded. This relates to the supply side of our services. As you heard from us, 50% of our hospital access is through the private sector. The other 50% comes from the public sector. We have untapped potential on the private sector side, and we want to have them in our fold, but there are difficulties, there are issues. There are issues in particular related to what we call as package rates, the reimbursement rates that the private sector expects from a scheme like ours. And we, on the other hand, wonder how to come to the numbers that are the right balance. In the absence of no local DRGs and a huge paucity of cost studies, how do we go about it? And because a huge section of private sector is yet to be engaged in this scheme, when we are looking at our dream for expanding the coverage to other sections of the society in a systematic way, we find that this comes in our way. We want to learn how to look at creating package rates and reimbursement system which is evidence driven, which is fair, which is transparent, which is dynamic and flexible as it unfolds. We haven't really found a solution to this. We built our structure based on our experience from the state level schemes, and I was directly involved in this little work at the cusp of the program. We use a lot of common sense rather than evidence and rather than data and information. So this is now in a way hurting us, because as we move forward, we must move to a more mature system which is founded on evidence and science and not just expert opinion or good guesses. I hope we'll be hearing something about this in the presentations and also in the panel discussion. The second issue is a much broader issue. We are covering about 50% of India's population through PMJ. about 50%. And much of it is in the lowest 2 quintiles. In principle, it is in the lowest 2 quintiles. When we were unfolding the program, some of us were very overzealous to get as much of India's population as we could into the beneficiary paradigm of this program. But ultimately, the political wisdom prevailed, and the nation decided to focus on the lowest 2 quintile population. That's 40% of our population. Eventually, some state governments have increased the coverage, including other sections of the society, and that's how the 50% number comes up as the breadth of coverage that the program provides. Now, issue is that we want to systematically include higher sections of our socioeconomic ladder. How do we go about it? There is a discussion on the missing middle that we'll be hearing. Should they be co-paying? Should they be adding on through a different insurance mechanism? We have a huge unorganized sector. How do we encompass that? And that unorganized system section encompasses the higher 3 quintiles as well. It's not just that they're all lying in the lowest 2 quintiles that I'm referring to. So we have a challenge to meet the aspirations of people of India, that truly this scheme one day should be totally universal. Everybody should be a part. Some efforts are on, as you heard from our CEO. But what would be the way forward? And in particular, what is the way forward to access resources in a systematic way from people who can pay? The lowest 2 quintiles actually, by and large, cannot pay or should not pay. But the other sections can pay to an extent. We are looking forward to thoughts from within the country and outside the country as to how do we go about doing it. Because our dream is not fulfilled until and unless each citizen of India is a beneficiary of a universal health coverage scheme. And in that context, currently what we are achieving is huge, and it is the biggest scheme in its own way. But then we have miles to go before we sleep. I'm looking forward to ideas on both of these 2 points in particular, and it is a good meeting of minds today, 2 years down the line, as to how you all perceive an effort on the part of India in this regard, and how you think we should move forward, learning from your experiences across the world. I must also place on record that preceding the launch of the PMJ, there have been years of hard work, years of discussions, deliberations, and several of you have been part of those discourses online and offline. And I'd like to place on record the leadership of Dr. Srinath Reddy in this regard, who co-authored a report on universal health coverage for India way back in 2011. And he engaged with a plethora of experts from India to create that vision for all of us. And I was beneficiary of that effort and a student of that effort. So the point is that before we launched, we heard a lot of knowledge. But after we launched, perhaps we are doing this effort in a more formal way at 2.0 point of this program. And I'm so pleased to be looking forward to hearing your ideas, your guidance, and your thoughts in guiding us through further journey in this mission. Thank you so very much. And I'll come back at the time of panel discussion with additional insights. Thank you so much.
Thank you very much, Dr. Paul. Indeed, we have miles to go before we sleep. And I think what we have for the next hour are 4 country presentations, which are going to look at some of the challenges that both you and Dr. Bhushan have laid out to us in terms of where we are looking at what could be the potential experiences and a roadmap and options that may be available for us to pursue. So with that, what I would like to now request is we are going to have Dr. Mundi Harno, who is the Director, Planning, Research and Risk Management at BPJS, which is the Indonesia's National Health Insurance Scheme, JKN. And what he is going to do, there are many learnings that we can have from the comprehensive health of Indonesia of merging different existing schemes that were there and expanding terms of how that has worked or not worked as they have expanded that to the informal sector. So with that, I would really like to thank 15 minutes. Please share the experiences with us. Over to you, sir.
Thank you, Dr. China. Good morning, good afternoon, and good evening, Your Excellency, ladies and gentlemen, participants of this prestigious event. My name is Mindi Harno, the Director of Planning, Development, and Risk Management of BPJS Kesehatan, Indonesia National Health Insurance Organizing Body. I am honored to speak in front of you, expert and professional from international health authorities. I hope that this session will be beneficial to continuously improve the implementation of national health insurance in each country. Next. Next slide. Before I start my speech, please allow me to outline my presentation. First, I would like to speak about the general overview of the Jaminan Kesehatan Nasional or JKN. And second, I would like to talk about the history of the establishment of BPJS Kesehatan, especially how to merge the five existing programs to one scheme program. And third, I would like to speak some key achievement and finally some challenges. Okay. Next slide. Next slide. Ladies and gentlemen, the slide shown that the number of JKN membership, contracted health care facilities, and the satisfaction index increased continuously from 2014 until 2019. Members and health facilities satisfaction index are one of the target given to BPJS Kesehatan in the National Health Insurance Roadmap set by the government. The document stated that at least 85% of JKN members and 80% of JKN health facilities must be satisfied with the services provided by BPJS Kesehatan. The chart above shows the stable rise in membership from 2014 to 2019. In the past 6 years, the amount of JKN members increased about 90 million, mostly from the poor, subsidized by the government, private and informal workers. The projected figure in 2020 shows a significant decrease of amount membership caused by increase of unemployment due to COVID-19 pandemic. Furthermore, the satisfaction index was high in the first years, along with the high anticipation towards JKN, and dropped in the second year before slowly climbing until 2019. Although still below the target, but the improvement in satisfaction index is evident to BPJS Kesehatan commitment on service excellence. The chart below is the number of contracted health facilities, both primary care facilities and hospital, and its satisfaction index from 2014 to 2019. The growth rate of health facilities is lower than the growth rate of members, but their satisfaction index slowly climbed toward the target. Next. Next. This table shows the healthcare utilization in primary care facilities and hospitals since the implementation of JKN. It indicates that healthcare access has improved as financial barriers no longer exist. People can get healthcare by simply showing their JKN ID. This table also shows that the highest utilization comes from primary care facilities, which indicates that referral system is working and the role of primary care as gatekeeper is improving. The table also shown that the magnitude of JKN as it is being used by about 750,000 people on a daily basis. Next slide. Next. JKN merged from 5 different health insurance schemes into a single program. Formerly, we have 5 social health insurance programs, which consists of PT Askes as a social health insurance scheme for civil servants and their dependent. Jam Sostek is the scheme for private sector workers. Jamkesmas is for the poor and near poor. Asabri is for military and police personnel. And Jamkesda is local government social health insurance scheme. And finally, perhaps most importantly, JKN incorporate the informal sector previously uncovered by any health insurance scheme. Through JKN program, informal workers can cover and can enroll to the social health insurance scheme. Next slide. The establishment of a single payer, BPJS Kesehatan, by merging 5 programs was a massive political event marked with pros and cons from a different side. The House of Representatives, the Social Security Council, scholar, and several ministries support the merger. They base argument by emphasizing on administrative and efficiency, formation of law of large number, equity and benefit, and the fact that a single payer scheme is mandated by the law. On the other side, state-owned enterprise, insurance association, workers unions, NGO are against the merchant concerning about the impact on financial market to the large fund managed by the institution. Liquidation is a complicated process which requires more time to accomplish. Another important argument is the perceived inferiority of the new JKN scheme, which caused concern from members of existing program. However, despite the controversy, a national consensus is reached and the law on social security organizing body was enacted in November 2011. Next slide. Our key achievement of JKN in its 7 years of implementation are the 84% population coverage, the provision of comprehensive benefit package under referral system, primary care facilities as a gatekeeper is working, payment system reform from predominantly fee-for-service into cash-based payment and capitation. A study also shows JKN contribute about $19.5 billion to the national economy in 2021. Simultaneously, JKN protect about 1.5 million Indonesian people from poverty due to catastrophic health expenditure. Finally, the national health account shows that out-of-pocket payments have dropped significantly since the implementation of JKN in 2014 from about 43% to about 35% in 2017. This is a positive sign that JKN as financial protection scheme is working and improving. Next slide. There are, of course, some challenges. The financial deficit occur almost every year since 2016 until 2019, and give substantial pressure to government's fiscal capacity to subsidize the scheme. But in the end of this year, we are no longer in deficit as the government has increased the contribution rate. However, we still need to be cautious on the financial sustainability since the rapid change in the epidemiology, especially after the COVID-19 pandemic. Once the pandemic is over, there is possibility of utilization rebound as the majority of patients delayed their treatment and their health have worsened, which cause more severe cases. BPJS Kesehatan must reserve sufficient funds to anticipate this event. Another challenge is to leverage the linkage between payment and quality. In 2017, we have successfully reformed our primary care payment system from capitation to pay performance capitation. Continuous improvement on the payment system is currently ongoing. The next challenge is to implement similar system in secondary care or in hospital. Currently, hospital global budget combined with performance indicator is being piloted in several hospitals. The next challenge is on contribution payment compliance, particularly from the informal sector member. Most members from informal worker pay when they need health care and stop paying once care is provided. Numerous initiatives have taken place to make sure informal members pay JKN contribution timely, such as sending reminders, adding more than about and assigning JKN agents to collect late payment. Ultimately, we think that enforcement is the most effective way by linking late payment with administrative sanction, such as a termination of work permit, denial of passport, driving license, or other public services. A specific regulation on Social Security administrative sanction has been enacted, but in practice, it needs multi-stakeholders commitment and coordination to implement such regulation. For example, enforcing passport denial for non-enrollees require extensive coordination and system integration with the immigration office. Similarly, such coordination must be made between BPJS Kesehatan and the police department, investment office, and other related institutions. Finally, one of the biggest challenges is to cover the missing middle. This segment consists of predominantly informal workers with good health status and low insurance literacy. Around 16% of the Indonesian population fall into this category. In one study, the Indonesian government attempted several interventions to attract the informal workers to join the JKN program. One of which is free membership, where the government paid the contribution for the entire family for 1 year. Not surprisingly, only about 8% agreed to enroll to JKN despite free annual membership. When asked about their reluctance, most answer that they don't need health insurance because they are in perfect health. Low insurance literacy is one of the problems, and BPJS Kesehatan work tirelessly to educate the people about the importance of having financial protection before illness comes. Next slide. One of the strategies to expand coverage to cover the informal worker is by advocating local governments, particularly those with large fiscal capacity, to expand their coverage from the poor and near poor to also include the informal sector workers. To add incentive in 2017, local leaders who achieve universal health coverage are given a reward and invited to the presidential palace to celebrate the achievement of universal health coverage. Until August 2020, about 122 districts, 42 municipalities, and 4 provinces have reached universal health coverage, which is defined as about 95% of the population have enrolled to JKN. Next. Another strategy to expand coverage to informal worker is by adding registration channel to ease JKN enrollment. A mobile application called Mobile JKN was developed and have been downloaded more than 10 million times. Enroll to JKN is simply on your fingertips. Enrollment can also be done through BPJS call center, visiting our mobile customer service cars, public service malls, and BPJS Kesehatan brand office. All of these channels are connected to the National Citizen Database, which enable BPJS to identify each individual by their unique identification number and determine their membership status. Next. Finally, BPJS Kesehatan assign agent or kader JKN to conduct door-to-door recruitment. They provide information about JKN to more than 3.3 million households. They also serve as a reminder to pay JKN contribution routinely and collect late payment. To that, more than 75,000 new members have been enrolled by JKN agent. We call it kader JKN. They also have collected nearly 500 billion rupiah, or approximately about 33.6 million US dollar worth of JKN contribution from the informal worker. Moreover, JKN agent help handle complaints and information requests from the people. Next slide. And the conclusion. To conclude, JKN is in its 7th year of implementation. It has covered around 80% of the population, has proven to improve access to healthcare facilities, as well as providing financial protection from catastrophic health expenditure. The implementation of JKN reflects Indonesian government has great commitment to universal health coverage. There have been some achievement, yet challenge still exists. The missing middle remains to be a major challenge toward universal health coverage. Numerous initiatives have been made, but we consider law enforcement through administrative sanction to be the most effective strategy. Coordination among related stakeholders is a key feature to ensure effective law enforcement. Thank you very much for your kind attention. Back to you, Dr. Sinta.
Thank you so much, Pa Mudiharno. Really appreciate your very candid sharing of experiences and not only highlighting what the achievements have been, but the kinds of challenges that you have faced and you continue to face as we look at expanding the scheme, and also in terms of the contributory contributions. And I think that's provided very, very good and rich insights. We thank you once again for joining us. After having heard Pa Mudihano, I think now what we are going to do is move to Korea. In terms of Korea, it achieved universal health coverage in the 80s. And since then, it has developed one of the world's most advanced health insurance programs. It has a very sophisticated IT system, which has leveraged to manage a strong fraud control program. And as Dr. Bhushan articulated, one of the things that he is looking forward to in terms of experience sharing is the area of fraud control, because I think that is ultimately at the heart of the sustainability of a scheme, both in terms of financial as well as in terms of looking at that the health benefits do reach the populations that it is intended to reach. So with that, I would like to now invite Mr. Moo-Sung Kim, who is the Director General, HERA International Cooperation Department, the Health Insurance Review and Assessment Service, or what we popularly know as HERA. And he is going to share with us how Korea has sustained efforts through the robust fraud control system of HERA. Over to you, Mr. Moo-Sung Kim.
Good afternoon. Dear Your Excellency, Dr. Indu Bhushan, and dear all colleagues. It is my honor to share HERA's fraud control program and ICT systems at the PMJ second anniversary event. From now on, I will start the presentation under the theme of sustaining efforts through the robust fraud control system of HERA, Korea. Next. Next, please. This slide shows the history of NHI in Korea.
Dr. Moo-Sung Kim, if I can just interrupt for a minute, if you can be closer to the mic, that would be helpful. Your voice is a little faint. Thank you so much, and sorry for interrupting.
This slide shows the history of NHI in Korea. We started a medical insurance program for large companies with more than 500 employees in 1977. In only 12 years, Korea achieved universal health coverage for the entire population. But there still were over 200 insurers. This led to inequality related to the medical fee and each service. To address this problem, Korea carried out a reform in 2000 to integrate both insurers and built a single-payer system. Korean National Health Insurance System provides health security for the public. The Ministry of Health and Welfare supervises the overall NHI system. However, it is two independent organizations, HERA and NHIS, to operate the system. The National Health Insurance Service manages the eligibility of members, imposes and collects insurance contributions, and manages NHI budget pooling. As for functions of HERA and NHIS, please refer to the slide. Next. HERA was established as a claims review organization and started to review benefit claims from all over the nation from 1988. In 2000, when the integration reform took place, HERA was re-established as an independent claims review organization. In order to conduct claims review based on consistent review criteria, HERA was independently tasked with a special mission for claims reviews for the NHI system in Korea. Next. HERA's function can be classified as 3 parts. The task of rulemaking includes deciding on whether to cover, when to cover, and how much to cover a specific medical procedure or a medical supply or a certain drug. This is setting the basic standards for monitoring and feedback. Second task is monitoring the medical costs and quality. And this task includes claims review, quality adjustment, on-site investigation, drug utilization review, nationwide drug distribution system, and healthcare utilization monitoring. Lastly, managing the infrastructure includes collecting and managing health resources, forming data warehouse, and big data analysis. Next. HERA employs 6 specialized ICT-based systems to achieve HERA's goals and effectively utilize the collected healthcare-related big data. HDAS is used to collect and manage information about healthcare services provided and the resources status of healthcare providers. HRAS reviews claims and adjusts the quality of care with data collected from HDAS. PIPS is a provider-focused comprehensive data dashboard to provide the detailed status of each provider at a glance. HBIG is a data system that supports the decision-making process of various external parties, such as government agencies, researchers, and pharmaceutical companies by aggregating provided collected and externally collected data. HERA has widened the use of this interconnected ICT system piece by piece over the last several decades, developing it into a multifunctional network. Please refer to the slide for the rest of our systems. Next. This is how we use all the information collected. All information is stored in our data warehouse. Collected data includes not only on procedure, drugs, medical supplies, and medical devices, but all other healthcare resources. In addition to this, public data that are obtained from other government bodies, such as death, income, and cancer registration data, and private sector data from relevant companies are all integrated to form big data. With all this data from all providers in Korea, HERA carries out many functions. It generates national quality indicators, conducts quality adjustment, supports policies, monitors diseases, and detects frauds. We also operate the Healthcare Utilization Monitoring System, HUM, as dashboard. This is the main screen of a HUM system, and it shows the total health expenditure at a glance. And it displays the cumulative expenditure compared with the last 5 years and annual forecast. Next. Now let's take a look at claims review. Korea's main provider payment system is a fee-for-service. Objectives of claims review are waste prevention, public health improvement, and keeping healthcare costs at an adequate level. Claims review checks clinical validity and cost effectiveness, and if claim treatment costs are accurately calculated following benefit criteria. The claims submission method was computerized in 2001. HERA introduced the medical claim portal service MacPOS in 2011. Providers are able to file claims free of charge if they can use internet and just access to the portal to submit claims. I will talk about claims review process briefly. Submitted claims undergo the process of electronic checkup, electronic review, and cross review, and then review results are notified to NHIS and providers. Along with this process, we are conducting preventive monitoring through pre-check. Even after claims review is finished, other relevant data are checked again. And HERA conducts post-management such as on-site investigation to prevent fraudulent claims. Next. This diagram shows the workflow of on-site investigation. The order is fraud detection followed by the execution of the on-site investigation, and finally follow measures. Fraudulent providers are detected by fraud detection system of HERA, and at the request of HERA, NHIS, and civil complaint. Afterwards, targeted providers and selected after executing the investigation, administrative measures may be imposed depending on the result of the investigation. After that, enforcement monitoring might take place if the investigation found violations of either the Medical Services Act or the Pharmaceutical Affairs Act. The findings are sent to the provider. Next. Fraud detection system is used to detect providers with a high probability of fraudulent claims by analyzing claim patterns with accumulated data from claim details, health resources details, workforce, facility, device, type of claim verification, and data from external organizations such as Public Prosecutor's Office and Korean National Police Agency. Target providers for on-site investigation are detected and selected by rules. Frequently used rules are status of health resources, number and amount of claims, mismatch of prescribed drugs with dispensed drugs, duplicated services provided for the same patient, and service provided while leaving the country. Next. As a result, in 2019, HERA helped to save $1.4 billion of national health insurance budget, which amount to about 1.7% of the total claims amount. Accuracy rate of fraud detection system was 81.3%. The number of providers with fraudulent claims were 983, and fraud amount reached about $28 million a year. HERA is moving forward to the new normal. We are currently developing the digital platform to connect and utilize data in provider and patient level. And then we will continuously make efforts to reflect quality of care to claims review process. Next. three components: systematization, computerization, and data utilization are required to improve healthcare, such as sufficient financial expenditure and high quality of care. First, we established the system and policy where all providers across the country can participate and give influence. Second, we conducted business through ICT efficiently linked with the all providers. Lastly, we collect, connect, and utilize data in healthcare to allow database policy making, analyze performance of healthcare services, and provide virtuous circle leading to improvement of the national policy. Thank you for your attention.
Thank you very much, Mr. Musung Kim. I think this was very, very impressive in terms of what you shared in terms of the fraud management system. And I really liked your last slide where you sort of talked about how you need to have the policy and the system in place, how the ICT can be a backbone for that system, and the computerization. And when you have all of this processes and systems in place, they can only be of use, unless you really dedicate yourself to analyzing the data that's coming out of that and using the data. And what you shared in terms of the gains that have been made in terms of savings with just in 1 year is really, really very impressive. And the other major takeaway that we have from your presentation is this is not something which you develop a system and you say, okay, it's functioning well and forget about it, but this is something which is always evolving and you have to continuously improve on that and look at different elements to bring that in. I think this is now, we've really touched upon three major themes. What now we'd like to do is to move on with the theme of provider payments. And this is something which, again, both Dr. Vinod Paul as well as Dr. Indu Bhushan alluded to in terms of private sector engagement. How do you pay the providers? What's the right price, etc. So what we're now going to focus on for the next 15 minutes is to look at the DRG system of payment, that is the diagnostic resource groups, and how those can be used. And the reason we're focusing on this particular on DRGs is essentially because a lot of the countries are moving towards this mechanism for inpatient care. So with this, I'm going to request Dr. Karen Bredenkamp, who is the lead economist with the Global Health, Population and Nutrition Practice of the World Bank. She's also the practice leader for human development in Europe and Central Asia. And what she will do in the next 15 minutes, take us through some of the journey that Vietnam has gone through in terms of deciding whether DRGs would be the appropriate system. And once they decided to do that, what process have they followed? So over to you, Karen.
Thank you very much, Sheena, and good afternoon to you, Dr. Paul, Dr. Bhushan, fellow presenters, fellow panelists, and to all of you around the world who are joining this event virtually from your homes and from your offices. It is indeed an honor for me to be invited to present in this event that is celebrating the 2nd anniversary of the historic PMJ program. And indeed, listening to Dr. Bhushan's introduction, we can see that the program is indeed historic. The achievements that you point to are really mind-boggling. I am joining you today from Hanoi, where I've been living for the last 4.5 years, leading the World Bank's program in health in Vietnam, and as part of that, helping the Vietnamese government on their journey towards DRG payment implementation. In fact, Vietnam is right now on the very cusp of DRG implementation. Next month, less than a week from now, they will start to implement DRG payments in 3 of their provinces and subsequently roll this out to the rest of the country. Now, for those of you who might not be very familiar with Vietnam, it's in fact a larger country than many people realize. And over the last 2 to 3 decades, Vietnam has made amazing strides in raising incomes and reducing poverty. Vietnam is also a big spender when it comes to healthcare, and I don't just mean total resources, I also mean in terms of the resources that the government devotes to spending on healthcare. When it comes to hospital inpatient care, most of this is paid through the health insurance fund managed by Vietnam Social Security. Over time, the government has slowly and systematically reduced their supply-side subsidies to their government hospitals and channeled that funding instead through VSS. So the amount that VSS pays for hospitals needs to cover not only operating costs, but also the entire staff salary complement, as well as things like capital depreciation. So even though there are mainly public hospitals in the system, those public hospitals are not unlike private hospitals in the sense that they do not receive that much government subsidy and they have a large amount of financial autonomy. And I think that starts to get to one of the questions that Dr. Paul posed at the beginning. Currently, Vietnam uses a fee-for-service payment system to reimburse hospitals. In my presentation today, I will draw mainly on lessons learned from Vietnam's transition towards DRGs, but also from select experiences from other countries, and in particular the 9 countries shown on the screen right now, whose DRG transition experiences the World Bank has recently documented in the volume that you see before you. Next slide, please. As Sheena mentioned in her introduction, DRGs have become the main provider payment mechanism for hospital inpatient care around the world. They are widespread in Europe, as you can see by the countries colored in navy blue on the left, but they're also used in the Russian Federation, in Australia, in New Zealand, in the US Medicare system, and in a number of US states. DRGs are fast gaining traction in Southeast Asia too. Thailand was the regional trailblazer, and would highly recommend also taking a close look at the Thai DRG system. But Indonesia and Mongolia also pay using DRGs. China currently has different DRG payment systems in place in different parts of the country, but I understand that China is working towards now converging towards one national DRG system. And the Philippines is also on the road towards DRGs, having a DRG roadmap in place. Next slide. To quickly recap then, what exactly are DRG payments? So a DRG system, first of all, classifies hospital cases into groups that are, number 1, clinically similar, and number 2, are expected to use similar amounts of hospital resources. The DRG payment is a one-time fixed payment for a hospital admission case of a particular DRG type. And the price of that DRG payment is set based on the average expected resource cost, regardless of the actual cost of care for that individual patient episode. So for a particular patient in a particular case, the amount reimbursed may be less than the amount of resources that the hospital consumes to treat that patient, or there may be more than the amount of resources that the hospital consumes to treat that payment. But the level at which the DRG payment is set is sufficient to, on average, allow the hospital to break even and ideally retain a little bit. Now, DRG-based payments differ from the case-based payments that I understand are currently being used in the PMJ program, in that the payment is based on the diagnostic-related group into which the patient is classified. Next slide. So how does a DRG payment look in practice? Well, of course, doctors and nurses see patients, they make a diagnosis, they order procedures. Then those diagnoses and the procedures are carefully encoded using standard coding rules and guidelines. Typically, you have expert clinical coders to do that, but sometimes it's the doctors and nurses who do this themselves. Then a classification algorithm. We commonly refer to this as a grouper, and usually as an associated software program, is used in order to assign a specific DRG to each clinical case based on the information contained in those codes. Then, of course, payment is made, a particular payment for a particular type of DRG. Next slide. So why did Vietnam want to introduce DRGs? Well, Vietnam has a very hospital-centric delivery system. Hospital spending accounts for 73% of total health spending in Vietnam. And as you can see on the chart on the left-hand side, the average length of stay for hospital acute care in Vietnam is actually quite long both by regional standards and when measured against countries of a similar level of economic development. And then even within Vietnam, we really see considerable variation across hospitals in terms of the length of stay and in terms of the number of procedures and tests ordered for a case of a particular type. And the sense is that this is a large system inefficiency that a payment reform towards DRGs may help to remedy. Next slide. And as we start to get into the lessons, I think the very first lesson is to be very clear about the purpose in transitioning towards DRGs, or indeed any other payment reform, because otherwise that payment reform may well become an end in and of itself. But rather, you need to know what this is serving. Why are you making this transition? From efficiency perspective, I think the Ministry of Finance, the Ministry of Health, and Vietnam Social Security were very interested in better incentivizing hospitals to provide care that is clinically appropriate, in line with protocols, without the excessive services or average length of stay that we saw on the previous slide. But there were other reasons. They wanted to reduce the conflict between Vietnam Social Security and providers about whether the care that is provided is appropriate or not. This has been getting a lot of media attention, and in these articles we see VSS being accused of not paying the hospitals for the care that is provided. And the argument that VSS puts forward is that some of this care was not actually needed, and therefore is an inappropriate use of the resources that is held by VSS. VSS also thought that by using DRGs together with a global budget to allocate their available funds, they would be able to limit their financial risk and address the year-on-year deficits that they've been seeing in the health insurance fund. And I think this is very typical about the switch from a fee-for-service to a DRG payment system, in that it shifts the risk away from the purchaser and towards the providers. But there are also other reasons to use DRGs in the health system. And these reasons are not necessarily tied to payment by DRGs, but just to monitoring the provision of care using DRGs. The Ministry of Health thought that DRGs would allow for greater clinical standardization and thus quality of care provided. And the Ministry of Finance was quite interested in DRGs because they could be used to build measures such as case mix indices to compare productivity and thus performance across hospitals, therefore increasing the accountability for the resources provided to them. Next slide. So lesson number 2. Strengthen coding systems, coding quality, data standards, data entry, and reporting. The foundation of a DRG system is its coding, the diagnosis coding and the procedure coding. So first on the diagnosis coding, Vietnam formally issued the Vietnamese version of the ICD-10 coding system, which is the most widely used diagnostic coding system globally, for use in all of its hospitals in 2015 already. Since Vietnam also has a lot of traditional medicine practice, they also needed to take their traditional medicine disease codes and map them into the ICD-10 codes. Vietnam did this in 2018. The other part of the coding system is the procedure codes, and Vietnam had a national system of procedure codes. But because Vietnam wanted to adopt the classification system that had been used in other countries in its DRG payment system, it needed to map the national Vietnamese surgical and procedure codes to an international procedure coding system, and in particular ICD-9 CM, which they did in 2019. In general, investing continually in improving coding quality is very important. Coding quality is the basis on which the DRG payment is made. And therefore, if coding quality is poor, hospitals will probably not get the revenues that they are due. And so poor coding quality can thwart DRG implementation. But at the same time, because the DRG payment depends on codes, the hospitals really do have a strong incentive to quickly improve their coding quality once the shift to DRG payment happens. Next. Lesson 2 is also about data standards and data entry. When it comes to DRGs, there is a particular minimum data set that is needed in order to allow DRG classification. This includes information on primary and secondary diagnoses. It includes information on the procedures that are performed. It includes other information on patients. And so what the government needs to do is to set the standards for data that will be included in the claims forms that will be submitted by the hospitals to the health insurance agency, and to have those standards formally issued as the standard for the country. And Vietnam did this in 2017. Next slide. And finally, lesson 2 is about data reporting. It will help tremendously to shift to a fully electronic claims review system, as Vietnam was able to do in 2017. Since 2018, 98% of facilities have been reporting electronically. And this is not only hospital facilities, this is all the way down to the most basic primary healthcare facility in the country. Next slide. Lesson 3, adopt and adapt rather than build from scratch. And I think this particular lesson could probably be applied to many areas of health system reform, and is also probably the reason why we're all sitting here today, to learn from each other. But the particular example that I'd like to draw on is that of the development of the DRG grouper, which can be technically very difficult. So remember, the DRG grouper is the classification algorithm that's used to assign patient cases to particular DRGs. Vietnam decided they would not build their own from scratch. Rather, they wanted to adopt the Thai DRG grouper. And in fact, as we know from the case studies that we've looked at, and indeed many other examples across the world, most countries, in fact, adopt groupers from other countries and then later adapt it to suit their own context. And the reasons for adaptation could include variations in clinical practice or differences in the cost structure. And in fact, Thailand, whose DRG Vietnam is using, in fact, previously used the DRG from Australia and later adapted it. And Australia, in turn, had first used the DRG from the US Medicare system and then later developed their own. So you see that even countries that are really quite advanced and sophisticated in their health system development actually adopt and later adapt rather than build from scratch. Next slide. Lesson 4, know exactly where you're going and who's going to get you there. In fact, Vietnam has been experimenting with DRG development for more than years, in fits and starts. And eventually, the government realized that what they needed was an action plan, a very clear, a time-bound set of actions in great detail that would enable them to get towards their goal. And this action plan was developed and finalized earlier this calendar year, and after that the movement towards transition went quite quickly. Vietnam also set up a steering committee and technical working groups, each of which had very specific terms of reference. And in fact, globally, we see that the formation of a DRG unit or if not a unit, at least a very clearly defined team is critical to getting towards DRG implementation. And you can see some of the examples that we have from other countries on the slide, and they are quite varied institutionally in terms of where these DRG teams or units can sit. Next slide. Simulate the likely effect of DRG payments before transitioning to DRGs. In DRG payment reform, as in other provider reforms and other health reforms, in fact, there will be winners and there will be losers. And some of the losers will lose by quite a lot. So it is important to do these simulations in advance to try to understand first of all, the political economy that you are facing. Which hospitals and which provinces, where's your political opposition likely to come from? What are the coalitions that are likely to form? But secondly, it's important to simulate to help to mitigate the financial risk that providers will face during the transition to DRGs. They need time to adjust. They need time to adjust their clinical practice towards something that is more efficient before they are really placed at true financial risk during the actual DRG implementation. And indeed, also the purchaser needs time to adjust and learn how this experience will work. So Vietnam, in fact, did these simulations. They compared what hospitals are currently earning under the fee-for-service system with what these hospitals would earn under a DRG system as proxied by the case mix index, which gives you a sense of the combination of the severity of cases and the number of cases. And they were able to inform hospitals in advance of what the likely impact of the DRG system would be on the hospital's financial position. Next slide for our final lesson. Transitions take time, and they need to be carefully phased in. On the left, we see the time that it took for the 9 countries that were included in our case study volume to move from initiating DRGs to actually implementing DRGs. On average, it looks like this was around about 5 years. Seems like that's a good length of time to get ready. But of course, the countries that moved more recently to DRGs could move more quickly because they were able to draw on the experience of those who had gone before. As well as biding your time, it's also important to have an explicit phase-in strategy. You can do this like Vietnam is doing it, phasing in by geography, 3 provinces next month and others to follow. You can phase it in by hospital type. You could use a system of partial DRGs when only certain types of services are paid by DRGs, although for some reasons this is not the most recommended strategy. And then there are other more sophisticated versions, such as this one by Estonia, which allowed to slowly increase the share of total cost of each case paid by DRGs. Final slide. To sum up, what are the lessons from Vietnam? First of all, be clear about your purpose. Second, invest early in classification and procedure coding systems. And in fact, even if you don't think that you'll move to DRG systems anytime soon, this is really worth doing for a number of other reasons too, related to the quality of clinical care and the monitoring of hospital performance. Third, adopt and adapt rather than build from scratch. Fourth, know where you're going and who is going to get you there. Fifth, simulate the likely effect of DRG payments to give providers and purchasers time to adjust. And finally, remember that transitions take time and need to be carefully phased in. Take the time. Thank you.
Thank you so much, Dr. Karen Bredenkamp. Really appreciate your sharing very practical lessons in terms of how Vietnam has gone through thinking about DRGs and the steps that you mentioned. And, I think particularly what I take away from your message is like, each country's situation may be very unique in where it is, but I think the key learning is that we should not really begin from scratch. There are a lot of experiences from different countries, including Vietnam, that we can glean from, and to be able to study them, look at the experiences, adopt what seems feasible, and adapt. And the last message that you had in terms of gradually phase in new systems that you look at. Thank you very much for those lessons. Now with this, we would like to move on to the last presentation of our first segment. And I would like to invite Dr. Jeremiah N. Paul, Jr. He is the Head of Fiscal Policies for Health Promotion Department at the World Health Organization. But the reason we have called, we popularly call him as JP, the reason we have called him today to be part of the panel is not because he works at WHO, of course that's important, but the reason we have called him is that previous to joining WHO in 2016, he was the Undersecretary, which is really like a Vice Minister level position of the Domestic Finance Group of the Department of Finance, where he has looked and worked on fiscal reform, including the countries, in terms of Philippines, looked at fiscal and tax system, including the sin tax reform law. And what we are going to do over the next 15 minutes is to look at how, in terms of in Philippines, which has really moved on to providing and covers around 93% of its population in terms of where we look at the universal health coverage, and it's funded primarily through premiums from members and general taxation. And sin taxes really provide a very important part of subsidizing the premium to the near poor. And I think that's something which we'd really like to understand, how in terms of pro-health taxes can be used for having sustainability and having, in terms of a consistent flow of funds, as Dr. Paul had alluded to at the beginning. So over to you, Dr. Paul.
Thank you very much, Sheena. Good afternoon to all of you, or wherever you are. As I said, good evening or good morning, Dr. Bushad, Dr. Paul. Yeah, I'm going to tell you about the story of the Philippine sin tax reform. Of course, Karen used to worked with me in the Philippines. She was stationed there at the time I was working on sin tax reform. But I'm really a finance official person by heart, but it's really, I'm a convert to health. That's why I joined WHO. Let me begin by slide. I will begin by essentially beginning with the key messages, and after that tell you the story. The first key message from the Philippine experience is that raising key health taxes is smart. In the Philippines, we call health taxes sin taxes, and in 2012, it was framed as a health measure, and the Philippines was able to raise significant revenues from health, particularly from tobacco. In fact, it was a win for revenues, a win for public health, and a win for health equity. In this context, I would call health taxes as a revenue booster for UHC, and also a NCD prevention accelerator. The second thing is that soft earmarkings can win political support. Again, I am a convert to earmarking, but more of the earmarking of the soft earmarking side, because I used to be known as Dr. No. I said no, no, no. But in the case for sin taxes, when the President Aquino then wanted, it was his social contract with the people. Our Ministry of Finance agreed to stop the earmarking. So by linking revenues to UHC, the Philippines was able to simplify tax structures and significantly raise tax rates, particularly on tobacco. This generated huge revenues and enabling an expansion of UHC coverage for the poor. The next slide. This is really important. Finance and health officials need to work together. There has to be a dialogue. They have to be on the same page. Because of the political economy of reform, you need to have a coalition of champions or reformers from civil society, academia, and other sectors to push the public health measure. So that could generate fiscal revenues. But at the end of the day, I mean, finance officials really are interested in the revenue, but if they talk with their health officials and be on the same page, you can have cake and eat it too. The third, the next bullet is not just about the money. Spending wisely is important too. I remember when we were doing this sin tax reform, and I asked the Minister of Health, how much do you need for UHC? And he told me, how much can you give me? And I said, that's, so I asked the bank to essentially help us in providing for some sort of fiscal framework so that it involves efficiency, effectiveness, and good execution. So the approach essentially is integrated and comprehensive. And the last message is that WHO helped us in providing technical support to the Philippines in the formulation of sin tax and UHC laws. Of course, we work together with the World Bank and other institutions, also like the IMF. So let me start with my story. Next slide, please. The Philippines at a glance is a population of 108 million, GDP of 377 billion. If you compare it to India, it's really a small. The percentage of population covered by social health insurance is 98% according to the Philippine Health Insurance Corporation. And we have a decentralized health system. Next slide, please. This is the universal health coverage is a political choice, and political support at the highest levels is really important. In the case of the Philippines, made possible the game-changing sin tax and UHC laws. I mean, I'm saying that, in fact, during the signing ceremony of the sin tax law, President Aquino then said, many thought it was impossible to pass the sin tax reform bill. The enemy is strong, loud, organized, and has deep pockets, but as we have proven time and again, nothing is impossible with the Philippine nation rowing in one direction, heart in the right place, and ready to stand up for its principles. We had really, we have a very strong tobacco lobby, and it was them that really made, I mean, we had different industries also, the alcohol, but it was the tobacco industry that really made it difficult. And I would argue that the sin tax law paved the way for the signing of the new UHC Act, which essentially provides, in the words of President Duterte, by automatically enrolling our citizens into the National Health Insurance Program and expanding field health coverage to include free medical consultations and lab tests, the UHC law that I signed today will guarantee equitable access to quality and affordable health services for all Filipinos. So you really need political will to go over the hard decisions. Next slide. So this is really a cartoon of how the sin tax law was very challenging. In fact, we were hit by arrows, swords, and in fact, at the end of the day, it passed only by one vote in the Senate. That's how tight the challenge was. And of course, we had people that says no to sin tax is a job killer, and you have to kill the bill. But we also had pro-health advocates who frame, for example, sin taxes as an anti-cancer tax, because about 10% of deaths in the Philippines is due to cancer and linked also to tobacco use. Next slide, please. Universal Health Care Act, this is the latest one, although the PhilHealth Act was signed in 1995. This one is the most recent one, because here what's important is that we simplify the contributions. All Filipinos are now deemed members. You don't have to apply. I mean, you're deemed a members, but there's a payment. You're either classified as a direct contributory, wherein based on capacity to pay, and subsidized if you're an indirect contributory member. You don't need an ID. Automatically, you're a member. But again, and all Filipinos have access to preventive, promotive, curative, rehabilitative, and palliative care, with primary care services as a priority. Of course, this is progressive realization, because we need to make sure that it's doing step by step, but we are primarily focusing first on the poor as we expand and better the services. Next. Next slide, please. So I'd like to have a link. As I said earlier, the sin tax law was, Aquino said that it was his social contract. So what they essentially did was to simplify the complex tax structure, raised, and for politically started soft marking of incremental health to health. And under the 230, because of the success of the sin tax reform, the politicians now were able to be open to a deepening of UHE reform. And at the same time that the Duterte administration had other reforms like the Tax Reform Acceleration and Inclusion Reform Act, where they essentially reduced income tax rates. They further increased tobacco and alcohol taxes that were started by President Aquino, and expanded to include sin taxes or health taxes to include sugar sweetened beverages and vaping products. This may not be applicable to India because vaping products are banned. Next slide, please.
Dr. Paul, can I request you to wind up in the next
Yeah, okay, minutes, sure.
Please?
Okay.
Thank you.
Next slide, please. Next slide. The key point is that we need to simplify and increase rates. Next slide, please. The same thing with alcohol. So next slide. So this is how earmarking works. It goes to the general fund. The important thing is that DOH has to provide an expenditure report and submit a medium-term expenditure program. In other words, it's not a blank check. Next slide, please. So the sin tax was changed from incremental revenues, next slide, to total revenues, to 50% of total revenues in 2020. But what are the wins of sin tax reform? Next slide, please. It's a win for revenues. If you see here, the revenues going up, excise tax collections going up through the years from 2012 to 2019. Next slide. As a percentage of GDP, it has gone from 0.9% to 1.4% of GDP. Next slide, please. It had a win for public health. There was a reduction in tobacco and alcohol consumption. Next slide, please. As excise tax collections went up, the budget of the Ministry of Health also increased. Next slide, please. And most important, it increased the funding for the poor. If you look at the bar graph, from about 500 million in 2004, it became 71.2 billion in 2020. And there was also a decrease in smoking among the poor. Next slide, please. So it's also expanded the health service and coverage, including to senior citizens, including a no balance policy if you go to government hospitals. Next slide, please. So what are the bottom line, what we can learn and perhaps consideration for India? Raising health taxes is smart. It saves lives, mobilizes resources, addresses health inequities, reduces burdens on health systems, and target NCD risk factors. For example, in the case of the Philippines, NCD incidence about 69%. So the other thing, prevention is really the better than the cure. So we're really addressing problems before they become unmanageable. The second point is that you need to simplify tax structures and raise taxes on tobacco. Although India has really increased taxes on cigarettes, bulk of the what is smoked is really smokeless tobacco and other traditional products. You need to include them in the tax net, and you need to index to inflation and essentially simplify the tax structures. It's not just about the money. The third point, you need to consider absorptive capacity in all of these things and execution. Again, you start on primary health care and value for money. Spend funds wisely, because at the end of the day, money does not buy health. It's really, you want to make sure it has impact on the ground. Thank you very much.
Thank you so much, Dr. Paul. Really appreciate the presentation and sharing, how sin taxes have contributed to both in terms of increasing revenues as well as the equity objective. With this, we are at the end of our first segment of the presentation. And what now I'd like to do is to invite Dr. Vinod Paul to moderate the panel discussion. And we really have a very eminent panel here. And without really, I won't want to get into the illustrious background of the panel because many of them are known to us. I'd like to invite Dr. Mark Blecher, who is the Chief Director for Health and Social Development, National Treasury of South Africa. Dr. Srinath Reddy, President, Public Health Foundation of India. Dr. Ajay Tandon, Lead Economist, Global Health, Population and Nutrition Practice of the World Bank. And Dr. Winnie Yep, Professor of Practice of Global Health Policy and Economics at the Harvard University. And with that, I'm going to turn it to Dr. Paul to moderate the panel discussions. Thank you very much.
Sheena, mindful of the fact that we are slightly behind schedule, but we are going to let loose the creativity and experience of our four very, very eminent panelists. Welcome panelists, Dr. Mark, Dr. Reddy, Ajay, and Winnie, good to see you. Looking forward to your wisdom on this Manthan 2.0. I'm going to begin with Dr. Mark Blecher. Sir, you are on the other side of the table when we go begging for money. And we always wonder what strategies we should use, what convincing arguments we should use, what should be our body language. Should we look pathetic or should we look confident? Should we look respectful? Should we look convincing? What arguments do we use? It's a dilemma that I have faced, and now I practice and I often fail, but sometimes I do succeed. So we'd like to know from you, what are the tricks to convince the Minister of Finance to apportion a greater proportion of government spending on health? Over to you, sir.
Okay, thank you very much, colleagues. I hope you can hear me. If I could just start, I would like to just send my appreciation or commendation to Dr. Indu Bhushan, Dr. Vinod Paul, and Dr. Srinath Reddy. It's been so clear from so many countries how health reform has been driven forward by strong and bold and courageous leaders. So as we really appreciate, we watch internationally the work that you are leading. It's very important. Thank you very much. So I'm going to try to answer this, what I think is a very important question, maybe just from perhaps my more than 10 years experience of sitting, as you say, on the other side of the table, and perhaps try and give you 10 hints for more successful budget negotiations. So the first hint, if I may call it that, is the importance of building institutional capacity, strong technical skills and teams. You know, this might seem like a strange one to start with, but when you sit on the other side of the table, you look quite closely at the, in a sense, the strength of the team, the ability of the team to carry through this reform, the strength of this institution. In my experience, for example, we've had many successful bids. For example, if I look at health programs, from programs like the HIV program, the vaccine program, but in more than 10 years, no successful bids, for example, from the trauma program or the mental health program. And a lot of that talks not just to the importance of those programs, because all those programs are important, but they talk to the ability of those programs leaders to build successful teams, to bring in health economists, to bring in experts, to put together a successful budget bid. So institutions are very important. Okay, the second hint is any bid coming to a Ministry of Finance almost always needs a costed plan, a strong costed plan. And in the case of a national health insurance plan, it tends to have more complex elements to that plan than a more simple plan, say for a new child vaccine or something. So, it would often involve, for example, whereas something like an HIV plan or a TB plan might be an investment case, for a budget bid for something around national health insurance, it would often involve actuarial modeling around volumes, around prices, looking some population changes, so trying to project costs into the future. So a costed plan is essential for a long-term budget bid strategy. Just around that institutional capacity in point one, if I may just also add a second part to this, is that there's a timing of this to the budget cycle. Most ministries of finance go through a budget cycle where particular things happen at different times of the year. And it's very important for, the health team, the Ministry of Health team, to be very attuned to that cycle, to know their counterparts in the Ministry of Finance, to know when those meetings happen, to know when the bids need to be ready, etc., etc. So the engagement at the right times in the budget cycle to prepare for them is very important. The third hint, if I may give it, is that for a major reform, such as our esteemed colleagues in India are undertaking, it's essential to have a national health insurance or a financing plan. And preferably a financing plan has to be drawn up actually by the Ministry of Finance itself. It's very difficult for the Ministry of Health to draw up a financing plan. But the Ministry of Health, along with the President, can play a very important role in ensuring that financing plan is drawn up. And that financing plan needs to show how the cost trajectory of the health insurance will be met by income, say over a 10 to 15-year period, how the costed plan is met on the revenue or income side, and how it can be met through different financing modalities. Without a financing plan, many stakeholders, including in the public and the media, will be skeptical of the health insurance program, because they'll say, where is the money that's going to fund this program? Okay, the fourth hint, and this is more specifically for specific interventions, is around effectiveness, cost effectiveness, and health technology assessment. From a Ministry of Finance perspective, it's very obviously these are critical parameters within health insurance. It's critical to be able to show the effectiveness of interventions, the cost effectiveness, and having a National Health Insurance Institute, which is formally assessing cost effectiveness of interventions, is very helpful to a Minister of Finance, because although the Ministry of Finance is having to evaluate complex health sector interventions of which they don't necessarily have much expertise, so be able to rely on strong national institutes for health technology assessment can be very helpful. The fifth hint is around affordability. And simply put, cost is normally equal to price, P times Q, price times quantity. And quantity is linked to coverage and populations. So is the unit price efficient? And as was presented in the DRG presentation, it is much more straightforward to understand the price in a more, in a DRG arrangement than in a fee-for-service arrangement where price can just be all over the place. So it's far more reassuring to a Ministry of Finance to have a more manageable reimbursement mechanism. Once one's agreed on effectiveness and cost effectiveness, then coverage, and obviously India with a very large population, the issue of rolling out coverage is quite critical. But the step to expanding coverage is obvious, it's self-evident, once the intervention has passed the tests of effectiveness and cost effective. Okay, hint number 6. Spending and performance. Many ministries of finance will say no because they will say, last time we funded this intervention to our ministries of health, but they didn't spend the money or they didn't perform. So it's very important for, there's two parts to this, there's two sides to this coin, which you all know as funders, because everybody who runs a health insurance fund is also themselves a funder. So, one needs to see this quid pro quo that when you allocate funds, you have the monitoring and evaluation which shows the performance and that the money has been well spent. The 7th hint, and I have 10 in total here, is obviously well known but has to be mentioned as usual, are the political factors. Health is a very political issue in most countries. It is very important to voters. In many countries, elections are fought. Governments rise and fall partly on their health policies, and especially at the time of COVID, where people are very much need healthcare that they can trust. In this, one should not ignore the role of civil society and social movements and advocacy. In South Africa, we've had a major role of organizations like the Treatment Action Campaign, which have fought for AIDS treatment, and many others, having hundreds of thousands of people in the streets demanding certain demands, give weight to, in a way, to Department of Health requests, which is quite complementary and different but powerful. There are also many strategic ways that the health sector can play the political or employ political influence more strongly, for example, in involving the Ministry of Finance early in projects so that they know about the projects, in taking well-researched recommendations to the National Cabinet for discussion so that the President and senior members of the Cabinet can weigh in on the requests. Okay, number 8, benchmarking. Benchmarking is a very useful strategy because it continues to test countries and states against their peers. And by continually benchmarking funding levels, efficiency levels, performance levels against other countries, one continually says, well, look, this is how I compare to the others. And if one is underfunded by a quarter or whatever compared to other peers, that benchmarking helps to show people against their peers. So benchmarking is a very powerful tool, also between states and between countries. Number 9, because both India and, for example, South Africa and I think Indonesia, many countries are complex intergovernmental arrangements. To make decisions, it requires decisions which involve the states and the national. So there need to be mechanisms for national and states to reach common agreement and funding agreement. And so that requires structures and strategies for intergovernmental agreement. In our country, we have in our ministries of finance, between our national and our state ministries of finance, both at the technical level and the political level, we have committees that meet at least every month, but often more frequently, to reach common financing decisions across the levels of government, and that way get coherence. That's very important for countries that have strong roles of states. And lastly, number 10, just linked to the question, is health is an investment. Most economic theory does recognize social capital theories of growth. Most ministries of finance I've come across in the world do recognize the importance of health systems. And where there are some maybe weaker ministries of finance or delinquent ministries of finance, one needs to think also, what are the international structures by which ministries of finance and their peers come together around the health, the budget strategies of governments, the meetings that take place internationally at the UN, in Washington, etc., etc., because many of those meetings of finance ministers also do emphasize the importance of the health sector to growth. So that's my answer to your question. Thank you.
10 vulnerabilities of benevolent finance ministers. Thank you very much. We'll try them out next time and we'll inform you how much we succeeded. Our budget cycle is February. So both Indu Bhushan ji and I will surely practice what you preached us today. Thank you so very much. But I have a quick follow-up question, and that is in the wake of the COVID pandemic. Should we really depend on health taxes, sin taxes as a big strategy? And for so many of us, it's also a moral dilemma. So a quick take on that. If we go with proposals of this nature to finance ministers, increase health taxes, increase sin taxes, and we go with a guilt on our face that we have a moral dilemma, what is your advice? This is a quick one for you, sir.
Okay, thank you very much. I think it does depend on the country, but in general, and certainly in South Africa at the moment, sin taxes are very relevant in the post-COVID environment. And I'll try and explain a little bit why. South Africa, like India, had a very heavy COVID pandemic. We've had many people infected. We've had 40,000 deaths. And interestingly, our national cabinet took a stance of prohibition. They felt that both alcohol and tobacco should be prohibited during the height of the pandemic. A very strange response, actually, in a way. But they took this view that alcohol would worsen certain aspects of the pandemic, and smoking also because of the pulmonary effect. So it was a very strange response, but the outcome of the response was that amongst many drinkers and smokers was to say, don't ban alcohol and tobacco, rather tax us more. So in our context, there's a much greater willingness to pay higher taxes in this time. Now, the other thing is that one has to look at the way that the pandemic has affected the traditional sources of revenue. So in our country, many businesses have closed, unemployment has risen, many businesses are very distressed, many taxpayers are very distressed because they've been perhaps unemployed or underemployed for several months. Now, in that context, raising many other taxes is not a good idea. Many ministries of finance are going through a very difficult fiscal space. We have we actually see the fiscal deficit rising to 15% this year, and GDP growth declining by 7.5% this year. So, in the context where many other taxes are not suitable at this point, increasing sin taxes, in fact, is quite a potentially useful strategy, and our Treasury is thinking about that. I should also point out that our Ministry of Finance did put in place a sugar-sweetened beverage tax about 2 years back. We were, I think, the first country in Africa to do it, and we did it partly because we recognized that chronic diseases are now overwhelmingly the biggest cause of death globally. There are, of course, dimensions and the time taken to prepare the administrative authorities to collect the relevant taxes, but this is the first tax that we did predominantly because of its health benefit. Perhaps we could call it the first true health tax. Even though, you know, alcohol and tobacco taxation in our country, like many other countries, and almost in every upper income country, high income country, are significant sources of, those taxes are very well and entrenched for many decades already. Thank you.
And please continue to stay around. There may be questions to you from the participants. Thank you so very much. May I now welcome Dr. Srinath Reddy and pose him an important question, and that stems from some of the issues that Indu Bhushanji raised about continuum of care. You know, we have emphasized that PMJ is about hospitalization, it is about secondary care and tertiary care. It does not include primary care. It does not include outpatient services. And the reason for that is, partly the reason for that is that these services are envisaged as a part of the second pillar of Ayushman Bharat through our primary health care outfits that we call health and wellness centers. So primary care is universal. It is for everybody, and it has foundations at the family level, so to say, at the community level. But what is your advice that, in very practical sense, should PMJ foray into outpatient care as well, into primary care as well? Over to you, Dr. Reddy. We can't hear you. We can't hear you, Srinath. Can you unmute?
Please unmute. Being disabled by the moderator. No, okay. My mic was previously disabled by the moderator, so that's why I couldn't. I'm sorry. Anyway, thank you. Thank you, Dr. Paul. Well, I think emphasizing the importance of primary care to you, even in the form of a response to your question, would be carrying coals to Newcastle. But nevertheless, in the context of Arogya Manthan and PMJ and Ayushman Bharat, it is absolutely necessary to talk about how important primary care is, and also how closely it has to get integrally connected to the PMJ as well. I think we definitely need to focus a lot more on this connectivity between primary care, secondary care, and tertiary care, both as a public health imperative and as a health financing imperative. From the point of view of public health imperative, obviously the continuity of care, chronic care, and connectivity of care is going to be very, very important, and therefore integration between the different levels of care is clearly necessary. But even from the health financing imperative, apart from making the very clear argument that unless we actually invest a lot in primary care and outpatient care, we are going to continue to have high levels of out-of-pocket expenditure, knowing as we do that the larger portion of out-of-pocket expenditure in India comes from these sources rather than from just hospitalized care. But equally importantly, if we are planning to move towards, as we must, towards a capitation fee system rather than just a fee-for-service system, then clearly, again, we require these linkages to be established between primary, secondary, and tertiary care. And therefore, having the health and wellness centers, as well as the other elements of primary healthcare system strengthened, is going to be absolutely critical indeed. And we do need to establish these connections as quickly as possible. But we also need to build in horizontal linkages as well as vertical linkages between different contributors to the health system, public, private, and voluntary. When I say horizontal, I mean all willing, able, and competent service providers, whether at the level of primary health care, should be integrated, accredited, similarly at secondary care, and similarly at tertiary care. But we also need to have vertical linkages between the three levels of care. So creation of networks will ultimately be very helpful, and those kind of networks will actually help us function better in the steady state and can be quickly recruited when a public health emergency arises, rather than having to seek ad hoc partnerships and scampering around for solutions like, for example, during COVID-19 situation. But it is also important that we actually move towards a capitation fee system, which is going to be much more effective in terms of ensuring appropriate care at affordable rates, and therefore the strengthening primary health care, the health and wellness centers, as well as the elements of secondary care and connecting them to the tertiary care is going to be absolutely important. Otherwise, we'll only be treating illness after it has occurred and gone into a fairly serious condition, rather than actually emphasizing the need for prevention, health promotion, early detection, and cost-effective care. So that's my take on that. If I may.
Thank you, Srinath. I have a follow-up question from the observations being made today by more than one speaker with regard to health taxes. I'd like to see your perspective on the health taxes from the Indian context, the Indian, context in terms of our media, our democratic processes, and our sentiments, and so on. Your comments on potential for health taxes beyond general taxation.
Well, I'd rather call them sin taxes or consumption taxes rather than health taxes, because they're actually consumption taxes on consumption of tobacco, alcohol, sugar-sweetened beverages, high energy dense foods which are nutrient poor, or even luxury vehicles for that matter. But sticking to, for example, only tobacco and alcohol, it is very clear that these are important public health instruments for reducing consumption, because we know that taxation is one of the most important elements in reducing consumption. It is true that the poor are more likely to be affected, and therefore the argument has come that this is a regressive measure. It is not, because it is the poor who suffer the health consequences and are unable to get the health care they need. Therefore, it's not going to be regressive in terms of protecting their health. But it is going to be even more affirmative in terms of protecting the people's health if we actually devote some of these resources or the large portion of these additional revenues for universal health coverage, as Philippines has done. If we actually tell people that you're going to get much better health coverage and your out-of-pocket expenditure is going to be greatly diminished, your catastrophic health expenditure is going to be greatly diminished, and therefore the palatability of the taxation will become more important. But one caveat though, the regular health budget should not be diminished, because this should not become an excuse for reducing the usual allocations or even increasing them, because otherwise we'll get indefinitely dependent upon continued consumption of tobacco and alcohol, and that will be a perverse incentive. But overall, I believe the balance of argument weighs heavily in favor of imposing these taxes, and whether through the expansion of the general revenue pool or some level of earmarking, expending it for universal health coverage, and particularly for the healthcare needs of the poor, is going to be a very important element, including the whole area of primary healthcare for that matter.
Do you see a moral issue when you earmark part of the funds to be pulled into health spending or health budget? I don't. Of course, there is a risk of replacement, that the general budget may reduce by that minute percent. But at the same time, do you see, when you create a connect like that, how would people see it? How would the society look upon this from the Indian context?
Well, we have to give them the other argument, which is absolutely true, that by raising the taxes, we are driving the consumption down. If you look at even what WHO says about tobacco taxation or the World Bank says about tobacco taxation, their argument is that it is the most potent instrument available now for reducing tobacco consumption anywhere in the world. And we have evidence from South Africa, we have evidence from France that consumption does go down when the taxes rise. Therefore, it is actually an affirmative public health policy. But in addition, if we actually utilize this additional revenues for universal health coverage, which is for the actual betterment of the people, I do not see a moral hazard.
But what about taxing alcohol enormously? Why are we shying? We want to kill the cigarette industry, which is fine, or reduce consumption thereof. But why is there always a mixed feeling about taxing alcohol?
Well, I have no problem about taxing alcohol. In fact, I would be an advocate for taxing alcohol also at a higher level. And the important issue is that we should utilize these additional tax revenues for a proper public purpose. And taxing any of these elements is a good idea, actually, including alcohol. But it depends always on the strength of the lobbies who lobby against it. And we need a strong political will and a public sentiment that can be built around UHC to counter those lobbies. Because if you can actually get the people to say these additional revenues are going to be improving the health of my children, and they're going to pay for the healthcare costs of anybody in the family, then obviously the taxation becomes a public cause rather than just a sort of individual push by a small public health group.
Thank you, but Srinath, the last one on this, I won't leave you. But why there are no lobbies talking about, alcohol taxes much more than some of the other lobbies that are angling for taxation on tobacco as of now? Why there is, alcohol produces huge ill health and so on, and why there is so much of less effort in regard to alcohol deconsumption and taxing?
Well, there has been a historical trend towards a global move against alcohol, against tobacco. But the real reason why the anti-tobacco campaign picked up was the effect of second-hand smoke. When it became very apparent that not only the smoker is injuring himself or herself, but is posing a health threat to people around him, whether they're family members or co-workers, then it is the second-hand smoke that really triggered the outrage and created the movement much more strongly. Of course, alcohol too has some of these in terms of drunk driving and accidents. It also has the impact of increased domestic violence. We need to push that up as well. But in terms of actual contribution to burden of disease, tobacco is definitely ahead. And therefore, we do need to pursue both. There is no question about it. It's not either or. But tobacco has had a historical advantage in terms of public health movement, partly because of the large burden of disease and also because of the public outrage created by second-hand smoke, which is so clear in terms of its evidence.
Thank you very much. And I have a last question for you, a brief one. Would you like to make 3 suggestions to Dr. Bhushan how to increase the uptake of PFJ in small towns, large towns, urban areas? Because we feel we are weak there for various reasons. So would you like to give us 3 suggestions how to increase penetration of PFJ for the urban poor?
Well, in terms of Tier 2 and Tier 3 cities, clearly you need to have assured quality supply of services that people will trust. Now, for that, you firstly need to definitely invest much more in strengthening public's healthcare facilities in terms of district and sub-district hospitals. But for the private sector, certainly a variety of incentives can be provided, and Dr. Bhushan did speak about it. But I would like to say that if we actually encourage the creation of vertical networks between primary, secondary, and tertiary, and then introduce a capitation fee system then the private sector would automatically start investing in both primary care and particularly in secondary care, because that is where they're going to be actually seeing the payment stream coming from. On the other hand, they would be very happy to skim the cream off the health financing only in tertiary care and invest minimally in secondary care, as long as they're assured of their payment in tertiary care, which is the high payment mode on a fee-for-service. So if we actually create these networks and move to a capitation fee system, the private sector itself would be substantially incentivized to invest in secondary care, including in Tier 2 and Tier 3 hospitals.
Well, thank you very much. That's very helpful, and we would like to build on that suggestion in a more formal way. Thank you so much. May I now invite Dr. Ajay Tandon to help us with some ideas on how to expand the coverage in the context of India in particular, but even otherwise in general, to the non-poor, the middle belly. And there, as I said earlier on, the challenge is how do we create mechanisms for contributory coverages, contributions that can be collected and collated, particularly from the informal sector. Our informal sector is huge, 85% odd, clearly above 80% of our workers are in the, our labor force is really in the unorganized sector. So could you give us some practical suggestions how to really create pathways for contributory coverage from the non-poor? Dr. Tandon.
Thank you, Dr. Paul, and thank you, Dr. Bhushan, for this very interesting panel, and to the other co-panelists. Of course, of all the questions, I get the question that's the most difficult to answer. Dr. Bhushan said, this panel will give us answers. Unfortunately, this area of being able to collect contributions, in particular from the non-poor informal. So I'm not talking about the poor here, I'm talking about the non-poor informal sector, has been a key and very intractable challenge that many countries have faced. So I'm always reminded of a statement that Victor Fuchs made when in terms of financing universal health coverage. And the point he makes is there are two necessary conditions to be able to finance universal health coverage. The first is there has to be compulsion, and the second is there has to be subsidization. So compulsion and subsidization are key elements of financing universal health coverage. By compulsion, basically the meaning is you have to make it compulsory to prepay for health services, because you need the healthy to also prepay small amounts so that there can be a redistribution from the healthy to the sick. Of course, you need not everybody to get sick at the same time, otherwise that whole prepayment mechanism doesn't add to any inefficiencies. And of course, you can adjust the prepayments depending on one's ability to pay, and you can completely subsidize, as many countries do, including India, in terms for the poor, the subsidies for those who can't even prepay. So in terms of the compulsory prepayment, this can be a compulsory premium, as in a social health insurance scheme where a certain amount of your wage is set aside for financing healthcare. But compulsion can also be general revenue taxation, right? It's a compulsion to pay taxes out of which financing is done. So I think there's one thing that we do know, that countries do not make progress to universal health coverage through voluntary prepayment mechanisms. That's known now. That's out of the picture. So it has to be compulsion and subsidization. You can have voluntary prepayment mechanisms as supplements or as complementary schemes, but you can't count on universal health coverage on voluntary prepayment for a variety of reasons. One is, of course, adverse selection, what economists call adverse selection, and Mundi can tell you more about that, because what ends up happening is the sick sign up and join these programs, and so what gets paid in, the healthy don't, and for a variety of reasons, and so that ends up creating sustainability challenges for the health financing system. So as you mentioned, I think the big challenge here is really how do we then cover the missing middle? The missing middle, the poor will be covered by general revenues, by the government. The formal sector can be covered by social health insurance contributions that are easy to administer when there's formality. But really, countries have struggled with any form of trying to collect contributions. And over and over, we have seen pilots being done, experiments been done. There are a couple of countries that seem to have collected contributions from the informal non-poor. China is one example, Rwanda is one example, but really, even in these countries, there was some form of compulsion to try and get the non-poor informal sector to contribute. In fact, many countries have actually given up trying to collect contributions from the informal non-poor. And a recent example is Thailand, which in 2001 said anybody who's not in the, formally contributing is going to be covered by general revenue financing. Of course, that creates challenges because in some ways you want people to prepay depending on their ability to or their income status, and you do have people who are non-poor and who should be able to pay, but because of the mechanisms of how the labor market is set up or how the levels of formality are in a country, you may have to make that choice to actually expand coverage even to the non-poor informal sector or the organized sector, as it's called in India, using some form of general revenue financing to at least to cover a basic package. And I just want to add one more point, that really the culprit here is the level of formality in labor markets. So earlier on, when Korea and Japan and other countries were expanding universal health coverage, when they grew, their levels of formality also grew. However, it's been noticed since the 1980s or so globally that as countries have grown richer, levels of formality have not grown for a variety of reasons. Globalization, unionization has become more limited. So given that we are here in a situation where we have increasing levels of non-poor informality, and in the absence of any mechanism to make it compulsory to prepay, I think that the best strategy forward is to use general revenue financing to at least provide a basic package of services to all those who are in the informal sector, and then incentivize some form of prepayment. Perhaps the benefits packet can be adjusted. One suggestion that I would want to reiterate, Dr. Paul, please don't consider co-payments. Co-payments should not be a form of financing for the health system. Co-payments are taxes on the sick. So in fact, in many countries, there's a move, you may want to use co-payment to adjust utilization rates, but not as a core source of financing, would be my suggestion. And I'll end here with this question.
So that's a good answer. Ajay, I just want to mention that there is one state in India where for antedating PMJ, a universal scheme was thought in which the people were to make a contribution. This is Himachal Pradesh. And I do know that we had some hand in the conspiracy to create such a model. But I was pleasantly surprised that people came forward on voluntary basis to contribute to such a scheme. But obviously their education levels are high. But that is one place that we should watch as to what finally happens to that particular scheme, which is layered and aligned with PMJ. Let me ask you a quick question for a short answer. What is your advice with regard to provider payment mechanisms in the context of non-communicable diseases? Very precise suggestion that if you could give to us.
Yes, so I think my answer has already been given by Dr. Reddy. But really the issue here is NCDs are a very different animal. I don't have to tell you, you're a doctor, but just for the others, NCDs are chronic. Most NCDs are chronic conditions. Once you have an NCD, you're going to have it for life. So unlike getting the flu or some other sort of diarrhea and other sort of communicable diseases, once you get diabetes, you're a diabetic for life, and then for 50, 60 years, you are a patient, or the health system has to cover, and you may be seeking care at different levels, at the primary level, at the secondary level, at the tertiary level, for the same condition or for comorbid or multimorbidity conditions. So, so one point is that you want to incentivize providers by designing provider payment mechanisms that will have promotion elements. They need to be proactive in terms of screening. You have a behavioral element, and it's not just about treating somebody when they come in to see a doctor. It's also about what happens between doctor visits. The adherence by the patient is also very important. Of course, you can tweak provider payment mechanisms a little here and there and pay extra for screening, for mammographies, or pay a little bit more for keeping the diabetics adherence. That's sort of the more traditional way of adding on some sort of incentives. But really, the reforms that are happening that are very exciting in this space have to do with bundled payments and global capitation payments. And I'll just very briefly in 1 minute just tell you what that is. And the idea here is, just as DRG is a bundled payment for an episode in one facility, these broader bundle payments will pay you regardless of which levels of care you're seeking. So a diabetic for a given year, regardless of what care they may or may not need, is given a bundle payment, for instance, in Netherlands and in France. And what that happens is you need to have a network, a virtual network or a collaborative arrangement where the different providers come together, primary, secondary, tertiary. So regardless of what care the diabetic may need, these people share that amount, that capitation amount for their care. And so that incentivizes these providers to also keep the diabetes in check so that it's treated at the outpatient level, because otherwise they're held responsible for any hospitalization that happens. And the next layer is also moving towards what is called global capitation, where you have networks of providers that are paid capitation for anybody in the catchment area, regardless of whether or not they use services or not. So what ends up happening is, currently our payment systems, crudely speaking, are designed to provide resources when somebody gets sick. So when you go and when you get a fracture, you're paid. So now you're paid regardless of whether you use, and that sort of bundle payment incentivizes the providers to also keep you healthy.
Thank you very much. Thank you, Ajay. That's very helpful. I now move to Dr. Vinny here. Vinny, thank you for waiting, but we are all alert. And I have the first question to you is, help us with your wisdom on how to integrate different schemes, because we are currently grappling with that. PMJ as a lead scheme, and then there are small splinter schemes here and there, which are which need to be merged. We have been successful in doing so in some states, in fact many states, but there are other schemes which are best aligned and integrated. What is your advice in terms of the basic principles that we would like to follow?
Thank you very much, Dr. Paul and Dr. Bhushan and all the friends. I wish I can come to India. So merging schemes is one of the most difficult thing to do, and it's a fundamentally political economy problem, not a technical problem. So if the existing schemes, always the problem is that the generous scheme, what I said is the rich scheme doesn't want to merge with the poor scheme because they were afraid that they would be losing. I mean, even if you look at Thailand is still 3 schemes. Thailand is not 1 scheme. And so if you think about China, China has an urban employee scheme, an urban resident scheme, and then a rural scheme. And after about 8 years with very, very strong political support from the central level, China is able to merge the urban resident scheme and the urban and the rural scheme. Still, the employee scheme is separate because in order to merge, either the government has to put in huge amount of money to make the benefit package equal, or the employee scheme would have to feel that they're losing. They would have to subsidize the poor. The consequence in China of merging the urban resident and rural scheme is also the premium contribution is actually very similar, and 80% is subsidized by the government anyway, so the income is similar. But those who are living in urban area actually use a lot more expensive care. So it's actually ended up the rural population is subsidizing the urban population. So merging has always created redistribution, and whether explicitly or implicitly, that has created political economy problem. I don't have a solution, and for the countries that you see have successfully merged, like Korea, like Mexico, Turkey, it all has to come from very, very strong political will. So then it sounds very dismal. So then what can you do? If you cannot merge all the schemes in terms of benefit package, there are some intermediary steps that would allow you to still benefit from not merging the risk pool, but still benefit. One is set up identical information system across all the schemes. Second is to set up identical payment method to the provider for all the schemes, short of merging the risk pool. Third, I think that what India can consider is that instead of merging all the schemes to the most generous level, because that would definitely require the government put in a lot more money, and I'm not sure that is practical or feasible, is you can create a merged pool with very basic minimal benefit package so that everyone would have identical benefit package for a minimum. And for those who are already in a very generous scheme, they can still continue to enjoy their current benefit, but that's additional. In other words, it will be very hard to merge schemes by bringing everybody to the highest level because it requires a lot more money, which I don't think is feasible in India, at least in the short run. Or merge it to some lowest level because the generous one will feel that I'm losing. So I'm suggesting create a scheme of minimal benefit package of which all the contribution would be merged only up to that minimal level. And for those who are in an existing generous benefit package scheme, they still enjoy them, but that's an additional part. So you're allowing a floor that is going to be identical for everyone, and the pool and the risk will be pooled, but allowing some of the existing generous scheme to continue to have that additional benefit. That's one potential solution that I actually had suggested to India multiple times because I just don't think it is feasible to try to merge it to bring it to the most generous.
Thank you, Vinny. This is helpful. That there are more than one ways of trying to integrate. That's helpful. I think this is an idea which we would like to explore further as the next phase of EMG unfolds. I also like to request you for ideas on strategic purchasing. We really haven't used it optimally in our system. But what are the best practices associated with strategic purchase that you would like us to keep in mind?
I think strategic purchasing has several parts which are important. And also, in answering that, I'll also answer a question of, in the case of India, how do you do strategic purchasing in a way that would allow you to purchase care from the private sector, which is, I think, a critical question. I think one key area to focus on in terms of strategic purchasing is actually provider payment method. And I'm not going to go through more of it because it has covered a lot and we can follow up with other detailed conversation afterwards. The second important part of strategic purchasing is actually the strategic purchaser itself. I think the strategic purchaser needs to really move from the approach of receiving money and paying out money, that is more like a bookkeeper kind of role, to really playing the role of buying on behalf of the people. And this means that within the purchasing contractual agreement, there needs to be very clear terms of what your provider is actually giving in return. And by that, I don't mean quantity of services alone. By that, I mean quality of services. And I think that's the part that most purchasers have forgotten. Most purchaser is really thinking about how much money I pay out, how much money I receive, and am I really financially insolvency, doing well. And that's really a bookkeeper role rather than a purchasing role. And let me just quickly get to the point of private sector, because I think India has faced quite a number of challenges in getting the private sector sign in. Private sector, by definition, are businessmen, so they're for profit. So the way to deal with private sector is deal with them like they're businessmen. I suggest that India really needs to do costing exercise. Cost out, whether you use fee for service or DRG or capitation, you have to get into a costing exercise to know if you want to buy certain care from whoever, what is the cost? Because that has to be the minimum. I'm afraid that after that, you will need to do negotiation. In area where you only have one private provider, they are going to negotiate a price that is higher than cost. In area where you have multiple private provider, you can go in and negotiate really hard to as close to cost as possible. But without that cost information, it becomes really hard for you to do that negotiation, because you really cannot pay them below cost, because that is unfair. But then you also don't want to pay more than necessary. And to what extent you can get them to accept a fee that is not more than cost or not more than necessary, depends very much on the market condition. And it depends on very much how much you have the purchasing power. So if you represent 30% of the population versus if you represent 80% of the population, of course the private sector will be very different. But sure, that is really a combination of what is the market condition, and unfortunately that's just the reality.
Thank you, Vinny. And one last one. I think we are losing your voice, but a rapid fire, short answer question. You know the India scene in terms of fraud and abuse. I think we have done well, at least we believe so. Would you like to make 2 suggestions to improve our fight against fraud and inappropriate, inappropriate use of services and wastage? So 2 suggestions from you that you think are helpful in our program. Vinny?
I will draw on Taiwan's experience quickly. 2 points. Number 1, information system is critically important. Number 2, once you have information system, but information system that is not fragmented, it's important to have information system that you can get a full profile of a physician, of a hospital, so that you know the full profile, not fragmented. Point number 1. Point number 2, who do you use to do the monitoring and identifying inappropriate care? Not NHA itself. Use the medical professional association to do that. Because when you have the medical professional association to identify the inappropriate behavior and monitor their own peer, that's much more powerful and effective than the insurance trying to do that, because you're on opposite ends and you don't also have the medical knowledge. So those are my 2 points.
Thank you. Thank you very much. We have exceeded time overall. What I intend to do is I will not attempting to summarize, but I'll just say things that I heard and then hand you back to Sheena and into Bhushanji for the final segment. What I heard is that finance ministers have some vulnerabilities and predictions. Make use of them. Sin taxes are welcome, including taxes against alcohol. Co-payments are bad. General taxation is ultimately the best bet. DRG is a good idea. Integration can happen through a strategic choice of individual pieces. And above all, what I heard is that we must use each other's experience to build our own system. So adopt and adapt is a great way forward. We don't have to start with the grammar classes. These are my quick learnings at this moment. Happy to hand you back to Sheena. You please take the discussion forward. I have summarized from my side. It's been enjoyable. Very, very high power, high intellectually, high intellect discourse that we heard. Thank you so much for the opportunity, NHA. Over to you, Sheena.
Describe.
She moderated it.
Quintuple or tentuple our efforts.
Sheena, you're mute. Sheena, you're mute.
Just do that as best as we can.
Thank you very much, Dr. Paul. I'd really like to thank all the panelists, who really contributed and enriched the conversation. I think what I'd like to do now, since a lot of the questions that have been coming have already been covered in the panel discussions, with that, what I would like to do is to invite Dr. Vipul Agarwal, the Deputy CEO, Ayushman Bharat PMJ and NHA, to propose a vote of thanks. Over to you, Dr. Paul, Dr. Agarwal.
Thank you, Sheena ji. Today was the third day of Arogya Manthan 2.0. In today's session, healthcare experts from various organizations and countries participated and shared international best practices. I would first like to thank Dr. Paul for chairing and moderating the event and setting the context for the insightful exchange of experiences and best practices. Sir, you are our constant source of inspiration and guidance. And thanks, sir, for being always there and enlightening us with your thoughts and ideas. Dr. Muniharno's presentation covered the strategies that Indonesia is looking at to tackle the missing middle, such as advocating local governments with high fiscal space to cover the entire population, adding registration channels, and assigning JKN agents to perform door-to-door recruitment. These are good learnings for PMJ. Thank you, Dr. Muniharno. Ms. Musang Kim's presentation focused on sustaining efforts through the robust fraud control system of HERA Korea, wherein he spoke of the six systems that make up the HERA ICT system. The learnings on the importance of systemization, computerization, and data utilization are key to all of us. Thanks, Mr. Kim. Dr. Karen Brennan-Camp of the World Bank spoke of the transitioning to DRGs payment in Vietnam. Her presentation on how DRGs are becoming the main provider payment mechanisms for hospital inpatient care and the 6 key learnings will be of great help to all globally. Thank you, Dr. Brennan-Camp. Dr. Jeremias Paul of WHO covered the experiences of expanding coverage using sin taxes in Philippines. The learnings that not only raising health taxes is smart, but that efficiency, effectiveness, and execution are also important considerations for impact and UHC sustainability. Thank you, Doctor. Thank you, Dr. Blecher, Dr. Srinath Reddy, Dr. Ajay Tandon, Dr. Vinny Yip for the exciting points that have emerged from the panel discussion. The points that all of you discussed were very insightful. Your perspective on health taxes, COVID, incentives to expand coverage, provided payment mechanisms, integration of schemes, strategic purchase approaches, concerns around fraud, waste and abuse will all be useful for PMJ and other schemes globally. I would like to thank Dr. Indu Bhushan, CEO sir from NHA for sharing the PMJ experiences for the last 2 years and helping set the context for the deliberations today. Last but not the least, I would like to thank Ms. Sheena Chhabra from the World Bank for coordinating this overall session on sharing of international best practices. Thanks to all. Thank you very much. Thank you.
I think we should give it a big hand to everybody.
Video
चला चला सेहत का पहिया, चला चला सेहत का पहिया, लाचार नहीं बहना और भैया, हर कोने में पहुंच रहा है सेहत का वरदान। रवैया रवैया, रांची से हुई शुरुआत, ई कार्ड बन गए हाथों हाथ, अस्पतालों का फैला नेटवर्क, अस्पतालों का फैला नेटवर्क, हुए करोड़ उपचार भैया, चला चला सेहत का पहिया, 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 पहुंच रहा है गांव शहर, इलाज खर्च अब नहीं फिकर, जन जन की मुस्कान बन रहा भारत आयुष्मान। रवैया रवैया,
देश के कोने कोने तक पहुंच रहा है मुफ्त इलाज के वरदान का पहिया, ताकि जीवन का पहिया चलता रहे, चलता ही रहे। शहर गांव खलिहान कोना कोना हो रहा आयुष्मान। आयुष्मान भारत पीएमजे, 5 लाख रुपए का मुफ्त उपचार प्रति वर्ष प्रति परिवार।
मेरा नाम रानी, 65 साल की उम्र है और हम घर के 7 मेंबर हैं। हम रहने वाले भल्लो माजरे, तहसील पटियाला। हम नरेगा का काम करते हैं और घर का खाना पानी चलता है इसके साथ। 12 साल हो गए बीमारी के, पथरी के। भाई साहब मैं 30,000 रुपया लगाया, मेरे को कोई फर्क नहीं किया, बहुत पैसा लगाया, फिर सरकारी कार्ड मिला मेरे को। ये कार्ड हमारे को सरपंच ने बताया, सेक्रेटरी ने बनाया, इससे कार्ड लेकर मैंने ऑपरेशन करवाया। ना कार्ड देते और मैं मर भी जाती, पर मैं सरकार का धन्यवाद करती हूँ।
आयुष्मान भारत हो, भारत आयुष्मान हो, आयुष्मान हो,